PhD, she was in Leeds, and then when she moved to Manchester, I followed her there, and then when she moved to Liverpool, she invited me to follow her there as well. So that's why you stuck with me today. So, that very kind introduction just said, I mainly work on patient identified needs. I'll tell you today. I'm going to go through what I do, the problems we have with treatment-induced pain in breast cancer, focusing on post-surgical pain, the impact of that, especially chronic pain, and how we use quality of life and patient-reported outcome measures in breast cancer surgery. So, a quick bit of background. Yes, I am ancient. I qualified over 30 years ago and started working on wards that did general surgery, including breast cancer. Did other qualifications throughout the years and ended up finishing my PhD in 2022. So now I've been working as a clinical academic ever since, and I still have the same interest and passion in patient identified needs as I did way back in 1992. So this is what my family and my friends think I do. My boss, I'm sure, thinks I spend most of my time at meetings and doing things, and unfortunately, it's usually the bottom middle one where I'm usually sat at a computer doing grant applications. But that's me with one of my patients on the other side, and that's why I actually do what I do. So the thing with breast cancer is it is the most common cancer in women, affects about 55,000 women in the UK every year, and have numerous different types of treatment that we use, and all of them cause pain in some way or another. So it is a big problem. Oh, and why is that not moved on? Oh, my slide's not moving on now. They were moving on, now they're not. Let's try again. Sorry. Try again.
Yeah.
If you read all the guidelines that talk about breast cancer and day surgery, of which about 95% of all our surgery for breast cancer is day case, according to all the guidelines, breast patients don't get chronic pain because it's not a painful surgery. I think you'll find the elephant in the room will tell you differently, and I've got some information to prove that in a few slides' time. We all know with all your backgrounds that chronic pain is multifactorial and caused by multiple different reasons, especially important when it comes to post-surgical pain. We do know, however, that the biggest risk factor is poorly managed acute post-surgical pain. So that's where I focus a lot of my energy and work in. Give you a quick run. I don't know if any of you work in breast cancer, but I'll give you a little bit of background, which hopefully may explain why we have so much of a problem with pain. And you will find quotes of anything between 50 and 70% of chronic post-surgical pain in breast cancer surgery. But when we did a local audit, it comes out about 45%, and that's realistically what it probably will be. Different types of surgery we use. You can have mastectomy where they remove the whole breast, a wide local excision, otherwise known as a lumpectomy, where they just take the cancer with an area around it. We can also do mastectomies with or without reconstruction. You can either do them as autologous, where they use the body's own tissue, or implant-based reconstructions. And then we get into the oncoplastic things, where they start using weird and wonderful type of incisional patterns, which can cause all sorts of problems and lead to pain, and also they reshape all the breast inside. So you can start to see why we're having problems with pain. Just in the wide local excisions themselves, there are different versions now of where they put the scars, which can have an impact on functionality as well as appearance and quality of life. And if you're looking at mastoplasty, where they're actually rearranging the shape of the breast or using a chest wall perforator flap, which is the current in thing. You may have heard of things like LICAP flaps or ACAP flaps. They're the most common ones we use, where they use a bit of muscle attached to vessels to try and make the breast look as similar to the other side when they've done it. So you can see why we're causing a problem. One of the other impacts that affects pain in the longer term is when we explain how we're going to remove the cancer to somebody, or even indeed to us colleagues. You say, you've got a cancer here. So if you see the picture on the right side, it's got a circle around it. So you've got a cancer, we're looking for a clear margin around it. So you think we're taking this nice sphere, which isn't a very large area, but what the surgeons actually do is they remove tissue from skin to deep fascia. So you can see on the other picture, it's more like a cylinder shape we take. So we're taking more, and then obviously the more you take, the bigger the impact, and the more you have to reshape the breast to make it look better. So again, it's going to have an impact on outcomes. If we're using reconstruction, can it have even bigger impacts? So you've got a normal breast there on that side. And what we do with the implants is you can either put them under the pec muscle or on top of the pec muscle. Pre-pec is a more modern technique. The one we always used to use is sub-pec, and as you can see, what they've done is they've taken the muscle here at the back and divided it and lifted it up to stick the implant underneath, so it like sticks it down to the chest wall. And can you imagine? Obviously, that is a lot more uncomfortable because we're dividing the chest wall muscle. So that is another reason why we could be causing pain. So looking at what are the post-treatment pain problems we do have in breast cancer. Most common locations, as you'd expect, especially from surgery, breast and chest, but we're also doing surgery in the axilla, so they can get problems there and down the arm. Then we stick radiotherapy on the top. So it's quite common for ladies to complain of flank pain, especially when they've had surgery followed by radiotherapy, and it feels like some get this tenderness, some get burning and tingling, others it comes and goes all the time. And also one of the more common ones in the last 15, 20 years since we introduced aromatase inhibitors, which are the like anti-cancer tablets that ladies get given after surgery. It mimics arthralgia, so it particularly affects the small joints of the fingers and the toes. So they've got multiple different potentials for different post-treatment pains going on. Obviously, in surgery, we have the potential of causing nerve damage, especially because we're going in the axilla. We do much more reduced axilla surgery than we used to do. They only take the sentinel node now rather than everything. So the chance of damaging the intercostal brachial nerve is a lot less, but they can still bruise it, stretch it, and that can cause all sorts of problems. It can take up to a year to recover. The other problem we have is whenever you've been having surgery around that area, it can cause problems with the shoulder joint, obviously inflammation, pain, especially if somebody's got pre-existing pain. And then we've got lymphedema, where they can get fluid buildup after the surgery or hematomas, all of which are going to add to pain. We do know, and as I'm sure you guys are the experts in this, obviously pain, whether it be acute or chronic, has a massive impact on quality of life. There are physical effects, which for our ladies can be limited mobility and definitely reduced functionality. I've had ladies who have had to change jobs or give up hobbies because of chronic pain, because they can't move the shoulder or lift or things. And then also the emotional effects that go with it about your quality of life not being what it was, and like say having to give up maybe things you loved before. And obviously you've got this circle of, the how you're feeling and your emotions affecting the pain, so it can become quite a vicious circle. And like I say, for all they always used to say that the reason chronic post-surgical pain in breast cancer surgery was so prevalent was because we used to do more radical surgery. People go, oh, that's not the case now. We do much more modern surgery. It's less invasive, less problematic. No, is the bottom line to that. I was a co-applicant and a co-author on a massive national trial that's been running for about 15 years. It's called the Mammo 50. It's the main aim of the study was looking at how frequently and how long after you've had a breast cancer diagnosis should we do your mammograms for surveillance afterwards. And over 5,000 ladies joined that study. But we also had a quality of life sub-study in which over 90%, so nearly 5,000 patients joined, and they were reporting all the way out to 10 years after the surgery and the diagnosis what the problems were. None of them were ones we weren't expecting, but pain came out as 35% overall, and at 10 years, nearly 30% of ladies were still saying that they had chronic pain. The problem is the reason a lot of healthcare professionals don't think it's a problem is because breast patients don't have follow-up. We don't see them, they have the treatments, they're discharged, so they're either being dealt with by the GPs or in the community, or worse still, they're not being dealt with at all. So that's where patient-reported outcomes come in. As you know, there's lots of different pain management strategies we can try, from medications, different types of weak analgesia right up to opioids, physical therapy, referring them to physios. Lots of ladies try complementary therapies, and we've also got self-management strategies. But my argument is, I think we need to be more looking at, yes, we don't want to not help those with chronic pain, but why aren't we focusing on better acute pain management, because then less of them are likely to go on to develop chronic pain. So where do we as healthcare providers fit in with this? I think the biggest thing, like I said, is about assessment. If we're not seeing patients and asking them, we're not assessing them. So how do we know and how can we offer help? So what I would say is we need to do regular pain evaluations, look at everybody as an individual, build a personal management plan, offer whatever form of support works for them. That could be emotional, could be psychological. We have a lot of ladies who see a clinical psychologist and will have ACT therapy, but also just patient education. And I found the biggest part of it is when I started working in this field was that most patients and even some healthcare professionals don't know of or get the link between poorly managed acute pain and the development of chronic pain. They think they're two different things. So that is a big place where we can impact. So one of the things I want to look at is we know we need to do all these things, but if patients aren't no longer in clinical follow-up, what format and what timing do we use to make sure we gather this information? What I would say is whatever we do, we've got all these options, we've got digital care, we've got more innovative trial designs with basket trials and trials within trials to look at different aspects. We have a lot of real world data as well that we could better use to help identify problems and come up with better ways of doing it. But whatever we do, it has to be what patients need and what is going to help them, because at the end of the day, they're the ones with the pain, not us. So some of the work I have been working on is about patient follow-up and quality of life, but that has a massive impact on pain. I work with Professor Velikova in Leeds, who's a world leader in EPROMs, and she developed a system called eRapid, and we use it in clinical care now in Leeds. It's about monitoring symptoms for ladies who are having chemotherapy. It is embedded within the electronic patient record. So people can see it, the healthcare professionals can see it in real time. Patients report what's going on for them, and it helps tailor the drug treatments that they're having. And I thought, oh, that's a really clever idea. Can I drag that into the surgical setting? Because let's say better manage pain acutely, less post. So I developed a similar system where patients would report their symptoms daily, because we need to get on top of it in the post-surgical settings. Let's say the day case, they go home, they're managing themselves anyway. They're just not doing it without any support or advice. And then they get tailored advice back on how to look after themselves. So it's what we'd call an EPROM intervention, and they are classed as a complex intervention. So what we do is we ask the patients to fill in a quality of life questionnaire or specific questions looking for the symptoms that we know will cause acute pain. So my system asks for things like, have you taken painkillers? Where is it? What painkillers are you taking? What's the pain score frequency? But then other factors like, are they not sleeping? Are they not eating properly? And it'll help. There's a couple of questions in there as well that help to identify difference between neuropathic pain and normal pain, so we can make sure they're on the right painkillers. So it's a way of detecting problems, monitoring the response, and it builds a better link between the patient and the doctor. Because like I said, the day case, they're at home managing, but we can still have an inside track of what's going on. And we do find it useful for when it comes to seeing patients in outpatients, because when they come back, it helps tailor a conversation in a time limited consultation where you can ask, say, oh, I see you've been having a problem with this. Can we help you with that? So part of this is about choosing what's the questionnaire we use or what are the symptoms we want them to report, how the results are presented, and I'll show you some pictures about how we did that, how we use it as part of a consultation, how we use it for education so the patients can better self-manage, and where we do that. So I developed this system called ePainQ, and I did it as a feasibility study for my PhD. It was done as a single centre non-randomised study in Leeds. We recruited 69 patients over 9 months, and we made it optional, so patients could either be standard of care where they didn't use the web-based intervention, they could do their own thing and follow the normal advice, or they could use the system. And as you can see, most of them wanted to use the system, so it was well accepted. So we followed the development of the MRC and NIHR framework for complex interventions, which goes through the pathway of how we get there. So it went through several stages of development. We did a scoping review, nothing was identified. Systematic review picked up studies that had been done, but none had been done in breast cancer at that point. And most of these sort of interventions were used in either mental health, diabetes, or chronic like lower back pain, things like that. Also did some development work where we did patient focus groups, we did interviews with healthcare professionals, which included everybody along the pathway from, the surgeons, oncologists, pharmacists, anaesthetists, right through to the GPs who deal with them later down the road. And then when we developed the intervention, we then tested it in the feasibility study. So I say that just encompasses a bit of what is involved in it. And what we're looking for basically is identifying what patients' needs are and how to help them better self-management, and then building that better contact between the healthcare professional and the patient. So what was in it? There was two aspects. There's a patient facing and there's a clinician facing. For the patient facing, we were asking questions from validated questionnaires and based on symptom grading, and that's how we worked out the tailored advice they were given. And the healthcare professionals could see what was being reported in real time in the electronic patient record. Also displays both for the patient and the healthcare professional in graph form, so they can track it and see whether they're getting on top of it. Is it the pain high and starts coming down, or is it all over the place and needs better management? Components were on the website. There's lots of generic information, right from the diagnosis, how they're feeling about things, and a lot of it is signposting to other symptoms. Patients we know are given lots of information and lots of paperwork, and they admit they don't read most of it. So it puts everything in one place that's easily acceptable, and it links. So if you read one section and it says this may be helped by this, it will then give them a hyperlink to another section. This is what it looks like when patients log on. So they have a website and have all the information down one side, and then when they come to reporting their daily symptoms, they just click on that lovely green button. That's a pain. Most of the questions that are on there are relating to pain and what painkillers they're taking. They also have questions relating to risk factors such as infection, seroma, hematoma, and then just general quality of life ones. And we also had a final box that said, have you got anything else that we haven't asked you about? This is what it looks like to them. We did it with pre-populated boxes, so it's mainly tick boxes. And then it's also got an algorithm behind it. So if you say no to something, it doesn't bring up the next question because that's really frustrating. And then you can see at the bottom there, it asks them to confirm what they've said is correct. And then it would give them some tailored advice, which is again based on an algorithm. And this was all gone through by clinicians and experts in the fields about what they should be taking and anything that can help, anything else they can do to help the management. This is it in a simple terms. So the patient reports that they can either do it on the phone, a laptop, a tablet. It was set up to do on anything based on what the symptoms said. Went into a colour coding. Either they were given self-management advice, they were given self-management advice, but also advised to contact the hospital, and the ones that were severe ones where we said you really need to be seen now, especially if we thought they had a medical problem. This is what it looks like to the patients, to the healthcare professionals, sorry, in the electronic patient record in Leeds. So they will just click onto that prompt button highlighted there. And this is what I'm saying. I colour coded it more for my sanity than anybody else's. So then when you're looking at it and you're reviewing what they're reporting, anything that's in green, we think, yes, it's not a problem. Anything in amber, we need to be keeping an eye on it. And anything in red is where they should have had an alert to contact the hospital. So like you can see there on that pain score, worst, it started quite high and was gradually coming down. So that's sort of pattern we'd be hopefully be looking for. And so you can have it in graph form as well. So you can see if it's been managed well or it's all over the place. So it's made up of different elements, some of which are patient symptom ones, which is about the self-reporting and the advice being based on grading. Electronic platform is vital. It's best if it's in real time, and it needs to be well supported by the healthcare professionals. If they're not going to use it, it's no point in it being there. Obviously, you can use advice and alerts. The advice is based on the symptom grading, but also it gives them permission to think, oh, I can take some extra painkillers. Oh, I do need to ring the healthcare professional. I'm not just going being a bit wimpy. But also the integration part is really, really important. It improves that communication, but you need to train both the patients and the healthcare professionals as to why you're using it, is it going to be used, and the benefit of filling it in. The one we have the biggest problem with is the electronic platforms. I'll talk about that in a minute. So I know this is very busy, very slow, but basically, like I said, we had 69 patients, 60 who wanted to use the study, use the intervention, and so that was really good. We followed them at 2 weeks post-op, 3 months and 9 months, so we could see who still had pain, at the time point at 3 months where it would go from being acute to chronic, and also 9 months is usually when most people have finished any adjuvant treatments like chemotherapy and radiotherapy. So we looked at it from a usability point of view, very high ratings for using it, and most patients did use it as we asked them to. The only ones who didn't stopped using it very early on, and that was mainly because one was ill, had to go back to theatre, one went to stay with a relative who didn't have the internet. But everybody who used it said it was simple and it wasn't a really complicated system to use. We also did interviews afterwards with patients who'd both used it, not used it, and chose to do the cohort arm. And from that, we've helped refine it going forward. So it's been reported in several places and was well accepted by people we spoke to and encouraged to take it forward further. So looking at the phases of complex interventions, we got so far and thought, right, we need to now do it as a randomised trial. So that's the next stage. I was successful in getting me and Professor at Briggs were successful in getting an RFPB grant, and we're going to test it in Leeds, Manchester, and Southampton, and hopefully Liverpool too, aiming to open in autumn this year. And it's going to be randomised, which is it wasn't before, and it's also going to be multi-site. So it's can you pick it up out of Leeds and make it work in different hospitals with different ethnicities, different patients, demographics, and with different IT systems, and that's where the challenge is going to be. And I say that's its full name, and that's what it's currently in setup at the moment. So the flow chart is basically anybody who's over 18, diagnosed with the breast cancer, who's having surgery is eligible, and they will either go into the intervention arm or the cohort arm. We're only following people up to 3 months at this stage because we're just wanting to see if we can reduce pain before we take it to a much bigger study. So we're not doing the 9 month time point. Lots of benefits. We hope there's benefits for patients and for staff and to the NHS. And overall, we want people to be able to better self-manage. That will have the benefits for the staff if they can identify those that are having a problem and rather than blindly trying to contact everybody. And for the NHS, if we can find a better way of supporting people and less people going on to develop chronic pain, then that is a massive benefit for the NHS, especially cost-wise. So how do we use EPROMs for symptom monitoring? There's been quite a lot of RCTs in different fields. We do know that the improve clinician awareness of symptoms, and that has a better impact on quality of life. We also know that the reduce unnecessary visits or emergency service contacts because they get the right advice at the right time and they don't need to go that far. It also means that we can build, like I say, that tailored support into patients based on the symptoms they report. But also, we do know that it needs to be co-designed with both patients and healthcare professionals because you need buy-in from both sides. And hopefully, what we do want at the end is to be able to change clinical routines and pathways to better improve it for everybody. So, like I say, EPROMs and monitoring is being used in lots of fields, a lot of it in cancer, especially when patients are having active treatment, especially chemotherapy. It's been used in lung cancer, breast cancer, germ cell cancer, lots of different things. Biggest important thing that's come out of this is about the communication and the fact that some patients need to know that somebody's monitoring, so they don't mind doing the reporting, but they'd like to know somebody's actually looking at it and doing something with it, because otherwise you lose interest and then you lose that data. So going through the current advice in advanced cancers, we do know that when added to routine care, as long as you've got a nurse monitoring it and keeping an eye on it, it really does reduce acute admissions, improves patient experience, and does actually benefit survival. In early breast cancer, including breast, we do know that it can also improve symptom burden, it improves patient education, but you do need to combine it with tailored support. And that's where we're coming with this. There's absolutely no evidence at the moment that you can use it to replace clinical contacts. You may be able to alternate it with, but that's something we're currently looking at, and I'll mention that in a minute. So again, because of that, we need to look beyond trials. How are we going to implement this when we come to the end of it? There's been a couple of reviews recently that are looking at how we use them in routine cancer care, and more people are starting to. In the UK, there's probably about 12 hospitals use this as a routine. A lot more use it as part of trials, but it's how do we take it from trials and put it into routine care, and you need to act on those 3 points. It needs to work at a patient level, a system level, and a professional level. Because if you don't have that buy-in, it's not going to work. So it's really important to think about what are the EPROMs that we're using to monitor, and it's also putting that bit of education in it to explain to people. A lot of people use questionnaires, but they use them for monitoring health-related quality of life as an outcome measure. But we're using this for monitoring and how that monitoring is then used to tailor the treatments that patients have. So it is very different from using it as an outcome measure. Technology is always a challenge, and that's something we're already facing and we already do. In an ideal world, the NHS would say, okay, this is a really good idea, put some money where the mouth is and get everybody access to the same system. That isn't going to happen in the short term. So a lot of us are having to develop our own systems, and hopefully the best we can do is get something that works in our hospital, potentially cross others, but at least come out with a toolkit. So you can say to other trusts and other systems and say, okay, this is what we found works. This is how you implement it. If you can either take ours and use it, adapt it to your system, or design something with the similar components to work in yours. But we do know that what we really probably do need to do is replace some of the clinical contacts we have, and then we'll need more testing to see if it's at least as good as. So the important things are about looking at implementation frameworks right from the point we're at now, where we're designing the studies, and about what you need to include. So you do have that evidence you need to be able to go to commissioners and to service, managers, hospitals, boards and things, and say, you need to put the money into this because this really works. We need to separate EPROMs into supported pathways and make sure they go in there. But you need to engage the full clinical team. You need that buy-in right from the start. Like I say, the e-platform is the biggest thing that we have battles with. Who's paying for it? Who upkeeps it? Where is it kept digitally? We do, like I say, need to have this co-production, and at patient level, I would advocate for an opt-out approach. We do that a lot in other aspects of healthcare. Rather than saying, would you like to use this? It would probably work better if we say, this is what we use, but you don't have to if you don't want to. Because we do know for any aspects of whatever we do, an opt-out approach has better engagement. And about encouraging people right from the start of the pathway, all the way through all the treatments, right to whatever end that is, so know they've got that constant support and that contact. So it's about normalising symptoms and self-reporting and encouraging patients not to sit on the symptoms. So with future directions, where we're going with this, we need a lot more research. That's looking at new pain techniques. But I think the biggest thing is long-term studies. As you well know, chronic pain is a long-term issue. And if you don't follow patients in the long term, you don't know just what the rates are, how bad it is, or what you can do about it. This is where things like the self-management and self-reporting interventions come in. We can provide, through the research and that, provide more evidence, which can then obviously have an impact on policies. It can make us improve our treatment guidelines and overall provide much better support systems. I just want to have a quick run. This is another project I'm currently working on that uses patient-reported outcome measures in looking at ladies who were having reconstructive surgery with implants. Because like I was saying, as I showed you earlier, we do know that there can be quite a big difference in pain between pre and sub-pec implants. So we wanted to, we're very good at quoting rates, be it for pain, infection, everything based on national figures. And we wanted to say, okay, what is it realistically at our trust? Can we better inform patients? Do they, because then we can give them a better choice of which type of reconstruction they want to have. Again, it was all female patients aged over the 18. Anybody who was having a mastectomy and was eligible for an implant-based reconstruction. So that could either be for risk reduction if they were a family history patient or if they actually had a cancer, could be one side or both sides. That's a single centre just in Leeds, and we followed patients for up to a year using the questionnaire. So we finished with 78 patients, excuse me, but 104 surgeries because obviously quite a few of them were bilateral. So 46, about 60% were pre-pectoral, where they haven't had to move the muscle and it sits on top of it, and about 40% were under the muscle. And what we did find is complication rates were about the same in both sides. So demonstrated that you can actually recommend to patients that could have either. It is a genuine choice. What was interesting to note, though, when you looked at the 3 months and the 12 months, so the longer term outcomes, is that satisfaction was more or less the same, but physical well-being was where there was a difference, even at 12 months, and that could well be explained by the different pain levels and how we affect what we're doing with the surgery. And that was all published just in case anybody is interested in that area. And another study that I'm currently recruiting into, because I'm very inventive with the name, so this is PROMIS, so this is for surgical. This is for standard wide local excisions. So we've done the reconstructions for the mastectomies. We're looking at the wide locals now and saying, okay, we know that this can cause you pain, can affect your functionality. It can depend on where we put the scar and what the type of surgery we have done. So we wanted to look at what impact are we having with our patients? Because as you can see from what's on screen, there's a big variation where some studies say, oh, it's fine, it doesn't matter where you put the scar or what type of breast conserving surgery you use, it's fine. Others say, no, it isn't. And the more recent American study, over 60% reported that they really did not like having their scars and it really affected them. So what we are looking at, we know it's standard care to offer wide local excisions, and the rate in the UK is around 70%. And it is a combination of making sure that we do remove the cancer, but also try and get the best aesthetic outcome we can. But like I said, messing about with it in oncoplastic and other things can affect pain and the quality of life. So what we wanted to do is we're using patient-reported outcome measures, both in the short term, pre-op, post-op, and long term, as to whether it makes any differences to the type of surgery we do. So we are looking at from a point of view of clinically, is there any benefit to one or the other? From a patient point of view, are there any problems like with, let's say, functionality? Because if your scar's in one area rather than another, is it more prone to infections, which can then lead to more pain? Another issue. So that's why we're collecting that. All patients that are eligible for having a wide local excision are approached about the study, and then, let's say, they fill in questionnaires pre-op and then different times afterwards. We opened the study in February and we're recruiting for a fixed 6-month period. Anybody over 18 who's having a wide local excision, as you can see by the list there, we do lots of weird and wonderful scars, and where they put them can either depend on where the cancer is, surgeon preference, where we can try and hide it, or if we want to try and make the axilla and the breast be able to be done through one surgery as well. So obviously I'll be able to, if I ever get invited back, present some more results about the importance of what we found with that. But just in summary, I just wanted to say, in that very whistle-stop tour of what I do, is it's the importance of comprehensive pain management, and patients are self-managing anyway, so why are we not helping them better self-manage, helping out the NHS and ourselves in the meantime, and use patient symptom reporting to get to a point where we can make chronic pain much, much less frequent, so the impacts less frequent as well, and therefore everybody benefits. And that's all I wanted to say for now, and thank you very much for listening. I hope that's okay.
Yeah, that's lovely, that. Thank you, Sue.
Absolutely.
It's quite an eye-opener as well, like the percentage of women that have chronic pain post-breast surgery. Never realised it was so high. You're talking about a third of patients, basically.
Yeah, that's part of the problem, I think, because every guideline you read, everything you hear says, oh, breast surgery isn't a problem. It's only when we do the big surgeries. But considering we know that 2/3 of the surgery isn't mastectomies, and yet the rates are still as high, it's and that is literally, we've just written that quality of life paper now that is just been accepted for publication. So that is literally up-to-date information.
Yeah, thank you. One of the things you were mentioning there was about sort of getting the buy-in clinically, and I know you mentioned sort of more like managerial, like who's paying for things. What about clinicians on the ground?
The clinicians on the ground, to start with, it can be a bit of a challenge. A lot of them are used to using questionnaires as part of research, but not always as part of clinical care. And I think it's about showing the difference it can make, encouraging that development with them, saying, okay, what would you benefit from this? And that's how we've tailored it, because it used to sit as a standalone system, and this is where the integration came in. Because clinician went, yes, I would like to know that information, but I'm not logging on to another system just to look at it. Can you link it to the system I'm looking at? So, okay, then we'll do that. And that is part of it. It's bringing them along with you.
Yeah,
And
yeah.
when you say, okay, we've got this idea, how do you think this should work? And that's what we did. We had all those interviews and focus groups at the start. So you've got the buy-in from the
Yeah,
start.
yeah. Okay, 'cause that's what I was thinking, is like people seeing it as something extra. Yeah, yeah,
Absolutely,
yeah.
absolutely. And it is difficult because everybody's so busy. But what they actually found, and we asked them afterwards, and we are going to do that with the study we're going, the pilot study we're going on to do now. It's about the ones from the feasibility study said they found it actually helped make consultations more focused, and they found it more useful because they could see what problems a patient had been having before they came in. They weren't just blindly asking them lots of
Mm,
questions.
yeah. Okay, thank you. Have we got any other questions for Sue? No. Oh,
Stunned silence.
David, thanks.
Sorry, I thought I'd give everybody else a chance before derailing everything, as I always do. So, um, I mean, a really interesting presentation, and cancer pain's something that I've and kind of well, anything to do with cancer really is not something I've spent a huge amount of time in the space of. I did say I was going to derail things, so here it goes. So my main interests are around neurodiversity and pain. So that's kind of where I spend my time kind of sitting. I guess two parts to a question. Within the data that you already have, would you be able to extract if any of your patients were neurodivergent?
No, that's not a question we particularly ask.
Okay.
But let's say going forward, we are hoping to collect more data. We do have a socio-demographic form we do give to people, which helps us identify, as well as like ethnicity. We're asking them about their educational level, how much they use computers and things like that. That is a question we could consider including.
Like I say, my follow-up question in that case is, with your new kind of trial, would you be interested in having a chat about that, and why, beyond the fact that I basically just run into rooms, scream neurodiversity at people, and then run out again in a slightly
No,
unhinged way.
you've absolutely found. My son's autistic, so yeah,
Ah,
been there, got the t-shirt, yeah. So it's like, yeah, no, that's why I'm I'm one of those people who says we should never. I'm one of those people who really annoys clinicians because I will. They have to find a really good excuse to discount something. I'm like, no, that's not a valid point. If the patient says they can do it, they're doing it. Yeah.
yeah.
So
Fabulous. In that case, do you want, if I'll reach out to you when I can,
absolutely.
when I have full vision again and can type without it being
That's it.
weird.
But you can see what you're typing. Yeah,
Yeah,
that'd be
yeah.
great, David. Yeah.
I thought you would get an email from me and it'll just look like someone's mashed at a keyboard for a while. So
No problem. Lovely.
Good. Okay, any other questions? I'm kind of thinking out loud a little bit because oh, Michelle's got one.
Yeah, it was just a comment, Sue, before I forget as well, in terms of certainly from a neurodiversity point of view, but an actual needing to think about how we collect protected characteristics and how we have the opportunity to think about how this gets delivered in different languages, because from an AI point of view, we could potentially translate it easily, and so that's something. I'm not suggesting you do that now, Sue, don't worry, but
No.
it's just keep a note, and we need to put a pin in making sure that we've got that we're actively including all people. And one of our challenges is those people, and you said you made a note of it in terms of a woman who went to somewhere where they didn't have internet access, is that there was about 5%, if my memory serves correctly, who were digitally excluded. So we need to think about how we capture that within the
We
pilot
do.
and
We
make
do.
sure.
And that's why
make
it's
sure
really
that that's
important.
captured.
Oh, absolutely. And that's why we captured some of the information we did originally. And like so we can build on that now with the rest. Because we do know that there are some people that are always excluded, but to be honest, there's people that are excluded from any treatment and anything that we do. And it's about trying to minimise that as much as we can.
And
We did
also
do some
shed a light on it. So even if we can't
absolutely.
deal with it, that at least we can be raising that as,
Yeah,
an issue.
and be honest about it. Because what we did find is we did some work in Leeds. It was basically around failure to attend outpatient appointments and why people didn't do that. And when they said, "Oh well, we can send you reminders. Have you got?" So they wanted to say, "Okay, well then if we send text, it's relying on people having phones and things." And weirdly, what they actually found was smartphone ownership was highest in the people who suffered the most deprivation. So you think that it would be lowest in them, but they actually had the higher rate of smartphone ownership. It was just they didn't have the data to go with it. So we're exploring options through social benefactors and charities and things as to you can like give somebody data so they can report it. So it's
We did
yeah,
some
we're
work
exploring
around
lots of different
like
yes,
patients who didn't want to do like our online PMPs, and none of that was around not having access to the
absolutely. Yeah.
software. Yeah, it was other reasons really. Yeah.
Absolutely, and that's the problem. That's maybe I should talk to you about that, Alison. There's multiple reasons, and you can address some of them. It's virtually impossible to address them all, but it's at least acknowledging that they're there.
Yeah, yeah. When did you start doing this work? Was it pre-pandemic or?
Oh wow, just literally just pre-pandemic, and obviously it's taken a long time to get started again. One, because I went back to frontline working during, and then it's
Yeah,
what happens afterwards. But also everything's gone a bit mad, and it's in a way it's given us actually more opportunities because people are more willing now
I was going to say it's become
to
much
look
more
at this sort of
accessible to everybody,
work.
hasn't it? Yeah.
Absolutely. We were like hitting our head against a brick wall when we started this sort of work. But now everybody's like, oh, actually, yes, because they had to do it over COVID. So they've realised the benefit of it.
Yeah, yeah. Okay. Any other questions? No? Okay. Right. Well, thank you for joining us. Oh, David, again, thanks.
Sorry, I'm just really. I was thinking more about some of the distress the patients must feel, and one of the big things we know about chronic pain is that anxiety and symptom-specific anxiety are kind of huge issues.
Mm.
But with somebody who's had surgery for cancer, there's the potential that pain is a reminder of the cancer they've had, but it's also potentially a reminder that they may be kind of, or that they may at least be hoping to be cancer-free as a result of the treatment they've had. So I can imagine that the emotions that patients must have as a consequence of cancer surgeries must be more complex than they might be for other kind of post-surgical pains.
Absolutely. And anecdotally, and this is one of the things we're exploring, anecdotally, like I say, I've worked in cancer for over 30 years. I worked on a ward that was half cancer, half non-cancer surgery.
Mm.
And people who have having surgery for cancer tend to be a lot more tolerant and will put up with a lot more symptoms in the acute phase. Hence the fact they tend to go on to develop chronic because they're like,
Yeah.
you've removed my cancer. Thank you very much. You've saved my life. I'll put up with these symptoms. Because a GP I spoke to said they very rarely see cancer patients asking for painkillers, whereas someone who's had orthopedic surgery is on the doorstep saying, give me more, give me more. So there is a very big difference in how people look at it. And like you say, there's the aspect of, is this my cancer coming back? That there's a worry. That are it's the fact that it's even when they want to forget about the cancer, the pain's a constant reminder that they had cancer because that's where the pain comes from. So it is very multifactorial and very complicated, which is why I want to try and better manage the acute pain so less of them get chronic pain, because then it's one less thing for them to worry about.
Absolutely. No, that's yeah. So this is why I've avoided cancer pain up until now. I've got enough interesting things to read about, and now I've got something else.
Oh, well, cancer pain itself is a whole different ballgame because that is pain caused by the actual
Yeah.
cancer, whereas, this is, we're talking about the treatments we give you that cause
Yes,
it. It's,
of course.
whole minefield.
Absolutely. No. Well, thank you.
Yeah, great talk. Thank you for joining us this afternoon, Sue.
No, well, thank you for having me.
And like I said, hopefully we'll have you back in the future.
Yep, more than welcome.
Right. Enjoy the long weekend, everybody. Bye-bye.
Thank you. Bye. Right.
Thanks, Alison. Thank you.
I'm sure.
Well done, Sue.